I can do that. I have, yeah. Do I have the access to his CV or something like that?
Yeah, I
Has he
will be
shared it in the
projecting.
group?
Harshal will, I'll be
Okay.
doing that. I'll be projecting it here.
Hi, Vishali.
Okay.
I have joined the.
Yeah, thank you.
Can you please share the CV?
Good, Dr. Surekha, welcome. So very good evening to all. So we are today in the third session of the Foxy ICOG Jogi Research Methodology web series. And the previous two ones, while they focused on the study designs, today we have the biostatistics. And we are very happy to have the entire team Foxy with us. We have Dr. Rishikesh Pai, who is the Foxy President 22-23, supporting us all the way, and I think everybody knows him very well. Dr. Lakshmi Shekhande, she is the ICOG chairperson and also the National Corresponding Secretary Association of Medical Women of India, founder, patron, and president ISOPAR Vidarbha chapter 2019-21. Highly accomplished, very approachable, and again on every session I always congratulate her for taking up this important the subject of research methodology where no chairperson had ever gone before. So thank you once again, Dr. Lakshmi. Dr. Geeta Balsarkar, who is the editor-in-chief of the Journal of Obs and Gynae of India 21-23, and she is also extremely accomplished, very well decorated with a lot of prestigious awards. Dr. Suvarna Khadilkar, she is the professor and head Department of Obs and Gynae, consultant endocrinologist and gynecologist of the Bombay Hospital, and also an accomplished teacher, recipient of many awards. And now I have Dr. Lakshmi to give a welcome address, please. Dr. Lakshmi, over to you, please.
Thank you, Radhika. And in fact, I congratulate you as ICOG chair in every program because you are the backbone for this Foxy ICOG Jogi web series on research methodology. And you have come out with a fantastic module that is 12 modules. And after completing 2 modules on study designs, today is the third module on basic biostatistics. So it is this research methodology web series is going great guns. So thank you to Dr. Radhika along with her co-conveners. And I also welcome our today's very passionate, enthusiastic young speakers, Dr. Nason and Dr. Sharan, along with all the chairpersons. And I can see Dr. Parag is here. Parag, welcome. And all the office bearers now, I see Geeta is also logging in. So Geeta, she is editor-in-chief of Jogi. So welcome Geeta. And I welcome all the delegates who have logged in for this fantastic web series. So without wasting any time, let us all learn from these esteemed speakers who have logged in. So I hand over back to Dr. Radhika for further proceedings.
Yes, so before we proceed further, I think it is also important that we know the team which is involved in organizing this program. So
बगल में ना चाय वाला आएगा तो वो पिला देना.
So that's me.
कोमल सबको म्यूट करो.
Yes, ma'am. Done, ma'am.
ठीक है.
Radhika ma'am, you are not audible.
Radhika ma'am, you've been muted probably.
नहीं, she is co-host. उनके 2 डिवाइस हैं.
Yeah. So now, am I audible now? So
Yes, ma'am.
So welcome all. So I work as a senior consultant in the Department of Obs and Gynae at the University College of Medical Sciences and GTB Hospital. I have my special interest in evidence-based healthcare and guideline development. I am a member of the Cochrane collaboration, Campbell collaboration, and also the LMIC representative to the Guidelines International Network. So the aim of this entire workshop is basically to have a basic idea and develop our own group of cohort of people so that finally we reach the aim of developing guidelines for our country. So the final, the broad aim is to develop the guidelines after going through these basic steps. and today's objective is biostatistics. So supporting me all the way are my two very accomplished the co-conveners, Dr. Vaishali. She is the professor and head at the MIMER Medical College, Pune. She is a consultant in critical care obstetrics, Ruby Hall Clinic, Pune. And she is also very accomplished and the recipient of many awards. And she is a university examiner for the UG-PG examination fellow maternal and fetal medicine at NUS Singapore. We also have with us Dr. Ranjana Sinha. She is very accomplished. She received gold medal during MBBS, chief consultant in the Gynae clinic at Patna, former head of the department of Gynae East Central Railway, Patna, and as you can see, long years of experience. So thank you very much for the entire team ICOG, Dr. Ranjana and Dr. Vaishali for always being there. Especially Dr. Lakshmi. And now I hand over the floor to Dr. Vaishali to please conduct the proceedings. Thank you so much.
Thank you, Radhika ma'am. All the dignitaries from Foxy, ICOG, and Jogi, with your constant support, we are this Foxy ICOG Jogi web series on research methodology, and today we are going to have basic biostatics. Looking at the response for last two sessions, we are really encouraged and we are really grateful to Dr. Lakshmi Madam, also the Vice Chairperson, Dr. Parag Sir, for always there to motivate us, and Radhika Ma'am, the way you are designing this program, we are really enjoying to help you in this and getting motivated to have more such. We are very happy to have eminent speakers and eminent chairpersons for this first session, which is on. First, we will have overview of types of data and their application, along with statistics for descriptive studies, for which we have speaker Dr. Sharan Murli from ICMR NIE Chennai. And to chair this, we have very eminent faculty and dear friends, Dr. Surekha Taide, Dr. Geeta Valsarkar, and Dr. Harshal Sabne. I welcome you, Dr. Surekha Taide, who is professor and unit head at JNMC Savangi Varadha. She is also chairperson, Global Women's Health Task Force Network, TUFH USA, advisory board member, the Network Towards Unity Health USA, founding member, Women and Health Together for the Future, South Africa, board member, Women and Health Together for the Future, South Africa, National Mentor Quality Improvement Lakshya Program by GOI, and Master Trainer for Emergency Obstetrics Care, Clinical Care. And she is presently a sitting chairperson for clinical research. We welcome you. She has many other accolades at her credit. Thank you for being with us today. Next slide, please. We would like to welcome Dr. Geeta Valsarkar, who is Editor-in-Chief of Journal of Obstetrics and Gynecology of India. Madam, we welcome you. Next slide, please. And we have Dr. Harshal Sabne, who is Professor and Head, Department of Community Medicine, SSR Medical College, and is FIMER Fellow, CMCL 2018. So we welcome you for this session, and I request Dr. Surekha Taide to introduce our speaker.
Thank you, Dr. Vaishali, for the kind introduction. First of all, I would like to congratulate ICOG Chair and team, Dr. Lakshmi Srikhande, for a wonderful program, and of course the convener, Dr. A.G. Radhika, and co-conveners, Dr. Ranjana Sinha, and my very dear friend, Dr. Vaishali Kode, for this very wonderful program which you have organized. Then I'm thankful that you have such a wonderful speaker also, Dr. Sharan Murli, whom I would like to introduce. Dr. Sharan Murli is a public health specialist and mentor at India Field Epidemiology Training Program. And he is a FIMER Fellow, as rightly said, and he's a scientist B, Non-Communicable Disease Division of ICMR, and also his research areas are non-communicable diseases, field epidemiology, and digital health. And we are, I must say that I'm personally know him as he has contributed in the research methodology book of Foxy, and I'm thankful that he's there with us to take us through the basic biostatics and the data analysis for descriptive statistics. So over to you, Dr. Sharan.
Thank you all. So it's really overwhelming for the both of us here, me and my the speaker to my colleague Dr. Mason. So I would like to first extend my gratitude and thanks to the entire fraternity here. And without wasting much time, let me just share my slide. Okay. So we all, have sometimes we start loving something, or sometimes we just turn our back on it. So back in the days, when I was trying to do my 10th standard and then to 11th and 12th, there was a question that was put forward to me that, whether I should write my maths exam. So I was like, no, because I'm studying biology. Why should I know maths? Correct. And I fought with my maths teacher and I said, I'm not going to write the maths exam. And then, she said, you are going to regret it one day, Sharan, that you will have to get back to numbers at one day or the other, even though you are becoming a doctor. So look at what I'm doing today, left and right, I'm working on, numbers. So I try to call it, the love-hate relationship between numbers, or, what we have in our day-to-day life, love-hate relationship with numbers, where you love it, but you don't love it because you don't make sense of it. So today in the first session, we are trying to see what are the numbers that we see on screen, okay, or what are the numbers that we see on papers. What is its essence actually, or what do I take out of it, or what do I do in research with these numbers? So that basically forms the descriptive statistics part. That's the first half of the lecture. So the point is, what do I gain from this? So I see more than around 50 participants here. So what do I gain from this session? You get to see what are the various types of variables and how to summarize each of this variable when you're conducting a research. We will touch upon some concepts, some rules, and yes, a lot of confusions, right? Because it's numbers at the end of the day. So let me start off with, imagine I'm trying to do a study, okay, on birth weight. Okay, maybe it might be in our labor room or in a hospital or in a district level data that we are trying to get. This is something that you all will be looking at, an Excel sheet with some data in it, correct? So we all start calling it data. So what do you see here? That's my question. So what do we see here? What do we see? We basically see something which is called as a variable. So the question is, what is a variable? An entity which can assume any value or something that changes from case to case. Okay, that is called as a variable. So broadly speaking, what are the two types of variables that we have? Either it's going to be a number or it's not going to be a number. That is not a number. Now let's have a look at the data that we have. See, if you broadly look at it, can you see there is a set of, there is a set of numbers, and then we also have another set which is not a number. So age is a number, birth weight is a number, and in between both this, can you see in blue color, we have sex, we have the socioeconomic scale, we have the delivery type, we have, whether the patient is a high risk or no, etc. So the data is basically going to be only two types, that is number or not a number. So let me try to put it this way. When it is not a number, it is going to try to explain a quality, whether the patient is pregnant, yes or no, whether the patient is married or unmarried, okay, that is marital status. So that is not a number, that is just, a quality, or we can even call it a categorical data. Whereas when we have a number, we try to quantify it, okay, something like the quantity, amount of gold coins, what is the age, which is a number, what is the gravida of the particular patient, what is the parity of the particular patient, etc. So basically it's just two types. Making it very simple, it's just a number or not a number. So here are some more examples that we can work out. So what is age? Okay, age is basically a number, correct? So when you try to put it, it can have a decimal point also. For example, I might be like 29 years, 6 months, these many days, correct? So there is a possibility of having a decimal point. Now come to marital status. There could be multiple options, right? Either it can be a single person, or maybe not yet married, that is basically single, or committed relationship, or married, or separated, multiple options. Go to parity. When you look at parity, it could be again a number, correct? Go to HIV status, whether it's positive or negative. Look at the stages of cancer cervix. It could be mild, moderate, or severe. Or look at years since marriage, especially when logicians, we look at data of infertility, years since marriage. That's going to be a number, correct? So that is again going to be a numerical, or basically a quantitative variable, okay? Don't worry, we have more examples coming up. So when you're looking at quality per se, for example, gender, we have like say male and female. I can also add a third gender or other into the same category, but it's again going to be a categorical thing or just a qualitative thing, correct? Quality. For example, when I say it's a female, there are a set of qualities that come with it, correct? So or when I say when it is a male, there are a set of qualities, some anatomical, some physiological, some hormonal things that automatically get attached to it. So that's why we call it a qualitative variable. Now you look at pregnancy status, yes or no. Pregnancy, yes. That means at the end of pregnancy, something is going to happen. That's a quality. Look at education, okay? There is no formal education, primary education, etc. Various categories of education. You look at the trimester of pregnancy. There is the first trimester, second trimester, third trimester, etc. So if you look at the first two, can you see that it is basically there are only two options. It is dichotomous variable. It is either male or female. It is either a yes or a no. There are no other options possible. But when you come down to the third and the fourth, which is maternal education and trimester, there are multiple options that are possible. There is no formal, primary, high school, higher secondary, graduation, any order, correct? And then you have first, second, third, etc. also. Okay, so that is called non-dichotomous. So the qualitative variables can be divided into dichotomous as well as non-dichotomous. Now, if you look at another characteristic here, I can write instead of male, female, I can also write female and male. Instead of pregnancy status, yes, no, I can also write no and yes. But when I go to maternal education, I cannot start with primary and take no formal education downwards, correct? Or when I'm looking at the trimester of pregnancy, I can't start with second trimester, then go to first and then come to third. That is banned, correct? So there's a certain order that is supposed to be followed. So when there is no order, you can call it nominal, something like a name. It can take any order. But when it has to follow a specific order which is defined previously, then it's called an ordinal variable. So another very common example of an ordinal variable will be our cancer stages, correct? So we always move from mild to moderate to severe. We can't start at moderate, then go to mild and then go to severe. So, okay, so that is another example. So that is about qualitative variable. Now what happens in quantitative variable? So you look at age. I can tell age is 23 years. I can also tell it is 45 years and 3 months. Or I can also decide to tell my age is 10.5 years. Because it is running in a continuous scale. Because time is running, age is also running. So it can take any value in between two whole numbers. So decimal is allowed in case of age. But if you look at gravida, okay, it cannot have a decimal, correct? I cannot tell the gravida of a particular lady is 1.5. Correct, we can't say that. So it has to be a whole number, 0, 1, 2. For example, the number of people in this room, the number of people attending this call, it cannot be 52.5 or 52.75. It has to be a whole number. So decimals are not allowed here. Or to be more specific, the numbers are very discrete. Okay. Now you look at weight, for example, or weight or height or BMI. In all these types of variables, decimals are allowed. Okay, so that's 8.9 because it's a continuous scale. Okay, my height is like 153. That's a 153.75. That's a continuous scale. Okay, coming to another example, number of pregnant women with hyperemesis in the OPD. correct? It cannot be 0.5. It has to be like say 45 people or 89 people or say 200 people, I can tell, but there is no decimal that is allowed. So to bring it out, some of the quantitative variables, the number variables could be continuous or they could be discrete. Okay, so to sum it up, we have qualitative variable can be dichotomous or non-dichotomous, and that can again be further divided into nominal and ordinal, and then we have quantitative variables which are discrete and continuous. Okay, so now if we look at this particular data, we again have the age, correct, which is a number. Then we have female, socioeconomic status, which are examples of qualitative data, and last May you have the birth weight, which is again a continuous data. So yes, I have my data. Now what to do, correct? So that is our prime question. So in most of the cases, okay, in most of the cases, we don't have enough resources to go to the population and sample the entire population or do the study in the entire population, correct? There is no resource, there is no time, and ethically there are a lot of problems. For example, if I want to find out the prevalence of a particular cancer among the women population in a particular district or service area of any of our hospital, we can't go to every door and knock the door, and get the female out and try to do a test on them, correct? It's ethically wrong. So we have come up with the concept of a sample. So from the population, something similar to the population we take out and do our study on this particular sample. So I need to test only these people who are in the sample. Okay, and then what happens? The results of the particular sample are extrapolated back to the population. Okay, so that is what we do in our day-to-day research. So when I explain the characteristics of the particular sample, that is what we call as descriptive statistics. When I extrapolate the results of the sample to the population, that is where inferential statistics is going to come into place, and that is going to be the top 2 of today. So in this session with me, we are going to walk through descriptive statistics. So we know that there are basically 2 types of data, correct? There is either a quantitative variable or a quantitative data, or there is a qualitative variable or a qualitative data, correct? So what are the tools of summarizing? So quantitative variables are usually summarized as measures of central location or central tendency and with measure of dispersion or spread. And qualitative is measured or summarized as measures of frequency. Don't worry, it will look a little, I told the love-hate relationship. You will hate it now, but you will start loving very soon. So when we go down, when we start looking at quantitative analysis, okay, let me try to bring a very basic concept of normal distribution. So when you try to plot the number of cases in y-axis and the age in x-axis, ideally, we are supposed to be getting something like this, which is called the bell curve, correct? So we are supposed to be having more people in the middle, okay, and then it just flattens out towards the end, and that is what we call a normal distribution. So when you look at the normal distribution, there is only one peak, and that the peak is in the middle, dividing the bell into equal 2 halves. And if that is the case, then that is known as a normally distributed curve or a normally distributed data, correct? So ideally, this is supposed to happen, correct? But most commonly or most probably it never happens. Say for example, I am planning to do a study among the women in a particular community or who are reporting to a particular facility. We know that young people have got better knowledge, so young people start coming to your facility more. So as a result, your curve gets shifted to one of the sides, correct? So let's look at that example now. So you can see that on the left hand side, the curve is more towards the younger age group, whereas in the right hand side, the curve is more towards the older age group. Say for example, I am doing the study in the hospital and younger people are coming. Then when you look at the mean, it is going to be different, correct? Because the center point is now shifted. You can see the center point is shifted. Okay, so this is nothing but a non-normally distributed data, or otherwise known as positively skewed data. Okay, so most commonly we try to see this in hospital settings, conducting studies on young people. Whereas if you look at the right hand side, there is one more curve which is a negatively skewed data. For example, I go to the community during office hours and try to grab the details of people who are there in the community. The young people have all gone for work, and the only people who are remaining in the community is going to be the older people. So what happens? The age distribution slowly moves towards the older age group. Okay, so now how can you understand, okay, what is my type of data? Do I know before itself that my data is going to be a normally distributed data or a non-normally distributed data? So in most cases, most of the biological data that we are capturing are supposed to be following a normal distribution. Okay, if you are following the simple random or the randomness in your selection of the sample from the population, but it usually doesn't happen. So where all should I be cautious that my data is not normal? If my sample size is very small, it is less than 30, or if my titer value, for example, I'm looking at some biochemical titer values or some laboratory parameters, let it be the diabetic value of a GDM mother, okay, or if I'm looking specifically at pain scores after analgesia and before analgesia, etc. When there is a discrete variable with a very narrow range, are you satisfied with the facilities of my hospital? Something like a quality check, you're asking them to put values in a Likert scale. Then what happens? There's a high probability that your data is non-normally distributed. Okay, so the question is, okay, my data is normal or non-normal? I find out that my data is normally distributed. Then what do? I find out that my data is non-normal. Then what do? Correct? So to describe any quantitative variable, you basically need to have two things. One is a central tendency and the next one is a dispersion. So the central tendency will basically try to tell me what is the middle point, what is the center point, and the dispersion will try to tell me how are the other values arranged around this midpoint. Correct? So that is what we are trying to find out. So central tendency has got the three most commonly used words, that is mean, median or mode, whereas dispersion has got the terms like range, standard deviation or interquartile range. So we will try to go one by one, that is mean, median and mode. Okay, so what is mean? Mean is nothing but the average value, and if the data is normally distributed, that is going to be the central value as well. As you can see the graph here, the central value is the mean. But if you look at median, definition is that is also the central value. You remember, when the data get skewed to one side, the median is changing, means the central value is changed, correct? And what is mode? Mode is nothing but the most likely value. We will do an example with this and then you will understand it better. Now let's look at it, okay? So in a symmetrical distribution, the graph that is shown in the middle, you have the mean that is equal to the median and that is equal to the mode. That is a perfect example of a normally distributed data. Whereas if you look at the left or towards your right, when the data is skewed, what is happening? The mean, the median and the mode are three different things. Can you see that the median is basically lying towards the middle of the data as a whole, but the mean is going towards the outlier or what we call the extreme most value. For example, we will do an example and then you will understand this. So here on screen, I am having a set of numbers, correct? So around 10 people's numbers are there. So if you could, calculate along with me, try what is what is mean. So what is mean? Mean is basically the central or the average value. Okay, so we try to calculate the mean by using the formula of sum divided by total number. So that is 361 divided by 10. So the total of all this calculation is 361 divided by 10. It becomes 36.1 years. Correct? So it tries to tell that in this particular data, 36.1 is going to be the middle point. Now let's try to calculate the median for the same data. Hello, is it all right?
Yes, it is all right. Please go on.
Audible.
Fine. So we are now trying, so we calculated mean, now we are trying to calculate the median, correct? So when you try to calculate the median, you cannot calculate median just like that. So we will have to arrange it. So I'm trying to arrange it in an ascending or a descending order. And then what happens? I should take the middlemost value, that is the fifth value. Here there are 10. So 10 divided by 2, that is 5. So I'm taking the fifth value, correct? So what is my median here? The number of observation is 10. Middle value is 10 by 2, that is 5. So the median is 26, correct? If you do an eyeball of the data, you can see that most of my patients are going to be in the younger age group. See, there are only 2 people, that is patient number 6, ID number 6, which is 45 years, ID number 7, which is going to be 100 years, correct? They are the ones who are driving the mean. Well, we'll come to that very soon. Now, if you look at median, which basically means the most likely value or the most repeated value, if you see, you can see age 26 is repeated twice and all the other ages are repeated only once. So the mode of this particular data, which is repeated the maximum number of times, is going to be 26. Now I'm trying to put all the 3 parameters together. So you have the data, you have the mean, the median, and the mode. Can you see that the mean is very high? It is 36.1, whereas the median is 26 and the mode is around 26. Okay. So what is happening here? Can you see that there is a huge outlier, that is 100, that is there? So because of the presence of the 100, the sum of every number is driven high, and as such the mean is driven towards the 100, that is towards 100, so 36. Whereas you look at median, if you look at median, it is trying to tell me, okay, my population is almost in the younger age group, whereas in 36 it's not very young, correct? So some basic concept will be the mean is dragged to the extreme by an outlier. So for a non-normal data where an outlier is there and the data is skewed, it is better to report a median. So median is going to be a better measure when my data is non-normal. For normal data, a mean is a better measure. Now the question is, when do I use mode? So whenever you want to report the number of episodes, say for example, the number of episodes of vomiting in a hyperemesis patient, or the number of times the patient is visiting your OPD, the number of diarrheal episodes, okay, for such concepts, the most likely number of values, then that is where you are going to use the measure called mode. So just to take back, so now we are trying to understand central tendency mein we will have mean, median and mode. For normal data, I am going to report a mean. For non-normal data, I am going to report a median. We also looked at when all the data could be non-normal as well. Now let's start looking at measures of dispersion, which is basically how is my data distributed around this central point, correct? So let's look at that. So we have another 3 measures. We have a range, we have a standard deviation, or an interquartile range. So range is nothing but lowest minus highest, that's it. So whenever you are reporting a range, you should mention that you are reporting the range. We will try to look at some examples and you will understand that. We have standard deviation and we also have interquartile range. Now let me just try to break down the concept of standard deviation. So for a normal data, what do we have in the middle? We have the mean, okay? Now to make use of this, normal data, I need to understand how my other data is spread. So standard deviation is nothing but how much is my other reading away from the mean. For example, if I am having like another value, say x, and how far is this particular x value from the mean? That is what we are trying to understand. So mathematically, when you try to calculate, okay, we understand that when you go from -1 standard deviation to +1 standard deviation, we have around 68% of the values within the curve. Okay, expanding it one more time, we understand that within -2 standard deviation to +2 standard deviation, around 95% of the values are coming. So if I know the mean and if I know the standard deviation, I can calculate from which value to which value my data runs, or the age, or the whatever parameter we are looking in our population basically runs. Say for example, let's look at the example. So this is how we usually report the mean or median in any of the report. Okay, so it's mean within bracket standard deviation, and that is equal to 24 within bracket 4. Now I'm doing some calculation for with you guys. So 24, which is the mean, minus 2 times the standard deviation, so 2 into 4 is going to be 16, and then 24 plus 2 times the standard deviation, which is 4, so 2 into 4, that is 8. 24 plus 8 is 32, which means with 24 in the middle, 95% of my values are lying between 16 and 32. So without telling where to where my data is, I am just giving you 2 measures, mean and standard deviation, and I am able to understand what is the actual distribution of age in my population, or what is the distribution of this particular variable in my population. Don't worry, we are going to do one more example on the same. So let's look at this particular data. We have the mean, which is 25, and the standard deviation, which is 6. So 25 minus 2 into 6 is going to be 13, and 25 plus 2 into 6, that's going to be 37, and around 97% of the values are going to be between 13 and 37. Okay, looking at one more example, if the standard deviation is going to be 3 with the middle point still at 25, can you see that the data is extending from 19 to 31? Okay, which basically means larger the standard deviation, the farther the cases are from the mean, which is the middle point is here, but the cases are very far away. That means I'm getting a very big bell. You can see that the bell is very big. Whereas when you look at the standard deviation, which is smaller, the values are more closer to the mean, and that is why the standard deviation is very small. Okay, so based on this, we are arriving at a basic thumb rule. That is, if the standard deviation is more than 50% of your mean, then you should suspect, oh my god, okay, there is some problem. Is it an outlier? Do I have an outlier, something like the age 100 that we just saw? Or is it an entry in the error? Okay, an entry error. For example, I looked at the labor room record and then I wrote the weight 2.4 kilograms was written as 24 kilograms, and suddenly in the birth weight study that I'm doing, there is a 24 which is lying and the data is skewed. So the standard deviation goes more than 50% of the mean, and then there is a problem, there is an entry error you have to suspect. Okay, and in most cases, if the standard deviation goes more than 50%, we are going to take it as non-normal distribution, and in non-normal distribution case, we are going to report median along with interquartile range. So now let's try to see what is interquartile range. Okay, so interquartile range is nothing but percentiles. So I hope if you have a child at home, or maybe a cousin who is going to school, nowadays they're going to tell you your child has scored 95 percentile or 99 percentile. So what does that mean? It basically means 99% of the kids are behind your son, and there is only 1% of people above him. Correct? So let's look at median. Correct? So what is median? Median is nothing but the 50th percentile, which is dividing our data exclusively into 2 parts, that is 50 and 50 on the sides. Correct? So when I tell I am 50th percentile, that means there are 50 people in front of me, there are 50 people behind me. Correct? That is 50 and 50. Now, when you start building it into 2 more pieces, okay, I am starting to divide it into 2 more pieces. There is 25, 25, 25, 25, correct? So that means there is 1 more percentile I am introducing, that is 25th percentile, which is called quartile 1, which means there is 25% behind me, 75 people in front of me. Now I am putting 1 more percentile here, that is 75th percentile. That means there is 75% behind me and 25% ahead of me, correct? So if I have these 2 numbers, that is Q3, that is percentile 75, and Q1, that is percentile 25, and if you minus them, that is going to be your interquartile range, or you keep it as such, that is going to describe your data along with your median. So when it comes to non-normal data, this is how you are going to report. You are going to report the median along with the interquartile range, which is nothing but your 75th percentile and your 25th percentile. Okay, let's look at one basic raw example of percentile. So we have a small data set here. So you can do 1, 2, 3, 4, 5, 6, 7. So the fourth value is going to be the middle. So that is 27 is going to be my median, and 8 is going to be my 25th percentile, and 65 is my 75th percentile. You can see that my percentiles are dividing my data into exclusive 25, 25, 25, 25 parts. Can you see that? So this is how you're going to report your data. So the median age is going to be 27 years with an IQR running from 8 to 65. And you can see that the median is not affected by the outlier, which we already discussed. So this comes, we have finished how to summarize the quantitative part of variable. We have one more thing to go ahead, that is the qualitative part. So
Sharon?
Yeah.
Sharon, can I just intervene? So
Yeah.
I think let's give it a halt for a minute.
Sure.
And let's find out from from the audience if there are any queries.
Sure.
For instance, there is something in the chat box. So Lata would like to know, in the bell curve, X is supposed to depict the age, but it's starting from 100.
Yeah, so the bell curve, we are supposed to show age. The age was one of the example. Here we have used BP example in the bell curve. That's the thing. That's why starting from 100 was mentioned as again.
Right.
I hope
So,
it's clear.
Yeah, it is very clear. So the point is, I had a query. So one is the postgraduate thesis and basic research that everybody does. So how do you think this is going to help the practitioners? If somebody is sitting and reading the literature, so I think it's of immense value to have the basic ideas about the statistics. So would you like to just also elaborate on this, how it would help a physician or a gynecologist who is just looking at the statistics? I mean translation to practice.
Yeah, so we will be finishing off the measures of frequency in the second half. We are doing that, no? Yeah, we are doing that in the second half of the presentation one.
Okay, so
We'll
the
be looking
practice.
at journal articles and how to decipher it out of it. So basically, for the part that is discussed till now, say for example, I'm looking at the mean age of a study population in a paper. Okay. So and the value that you're looking at you should understand that, okay, if they're showing it as a mean and a standard deviation, that means this is going to be the range of patients that they have brought into the picture. Say for example, I'm looking at some drug that is going to help in, say, CS cervix or something, and the study is trying to concentrate on the older population, but the mean age of the population is in the younger half, then you should know that there is something wrong in the study. Say for example, I'm looking at a study which is supposed to be concentrating on a population more than 50 years, but your mean age itself is 50. That means you should know that there are a lot of people who are less than 50 that is there in the picture. You're getting the point. So
very important.
Examples,
I think that's a very, very important take-home point of great practical value. Yes, please.
Yeah, one more thing, madam. So when we read an article, when we read a research article, so what we usually try to do is we will see whether we can apply that particular intervention in our setting, right? So when we do that, when in a journal article, usually they report either the median or interquartile range or mean standard deviation age. So when we read that, usually as the first paragraph, the results will show the socioeconomic characteristics of the study participants. So when we see if the mean age of the participants in that particular study is completely different from what from the patients what we get in our study setting, then we may not be able to apply. We may not be applied that particular intervention here. So we cannot generalize like that. So that is why it is very important.
Exactly. So for practical purposes and clinical practice, so translation to practice from the digits that we see, the numerical values, And also it is important to understand that probably to understand the basic concepts of a parametric, whereas a normal distribution, normally distributed data versus the non-normal distribution. So it's you explained it extremely well, but I just wanted a breather for the audience so that
Got it.
so
Yeah,
that
so
we are able to present. Yeah,
this is usually
please
a
proceed.
1 week session, ma'am, we are doing.
I know
Only
it's not
22
easy.
hours.
I just wanted a brief change. That's all.
Got
Please
it,
carry
ma'am.
on.
Got it.
Yeah.
Got it. So another example, just to pitch in on the same line, well, like what Nathan was telling, I am trying to give a drug and try to see the response to the drug. Say, if I'm looking at a variable, say the hyperemesis gravidarum and a laboratory value, beta HCG value. So that is going to be a laboratory parameter, and that is going to come back to you as a median and an interquartile range. Is there visibly a change between the both? Okay, so that is when you will actually look at, okay, so rather than just looking at the inferential statistics part, the p-value part, and reading the line as this is statistically significant different, okay, if the beta HCG value runs from say x to just x plus some small values, then those differences you should be able to pick up, because now you know that the middle point is the median and interquartile range is how the data is spread around. Okay, so just to give an example. We will come to more examples and more when we go to the next session, and we'll bring back again the same concepts there as well. So going further, let me just try to check. Yeah, so going further, in qualitative variables, we are basically going to look only at count, ratio, proportion, and rate. Okay, so what is qualitative? Qualitative is number of males, number of females, correct? Or number of people with pregnancy, number of people at each trimester of pregnancy, etc. So let me try to explain this with examples from apples and oranges, like I always do in the class. So if we are trying to tell the number of apples alone, then it is going to be a count. That means I'm going to tell only one number, that is a numerator. And we all are used to giving examples from just count. Like, there are number of people with pregnancy in my OPD is 20 or 25. Correct? Or number of people who are reporting with cancer in my OPD is 20. But how many people did you actually have in the OPD? Correct? So to further drill it down, if we try to compare the number of apples above the number of oranges, then it is going to be a ratio, because apples and oranges are two different concepts and you are trying to put them one above the other, it becomes a ratio. But we are trying to do apples, that is good apples, divided by total number of apples, where the numerator is a part of the denominator, then we start calling it a proportion. Okay, so if you report only the numerator, it is count. If you do A by B, where A and B are different, that is going to be a ratio. And when I do A by B, where A is a part of B, that becomes a proportion. Okay, trying to relate it to some OG examples. If you look at the number of women with cancer in your registry, then it's going to be a number, that is a numerator or a count. When you try to divide the women with cancer divided by men with cancer, it becomes a ratio. And when we try to do the women with cancer divided by the total registered patients, say for example, my OPD has got 100 patients on a daily basis, and around 20 among them are always coming with cancer. So 20 divided by 100, 20% of my total OPD load is going to be cancer patients, and that is a proportion. Okay, so we can bring out various examples for proportions. I will summarize it at the end with some more examples. Say for example, I have among the total number of cancer cervix patients reporting to my facility, okay, how many of them are coming in mild stage? Because I have got time to treat them. How many of them are coming severe? Then it's difficult. So severe disease divided by total disease, that will become a proportion. Or among the total number of deliveries that is happening in my labor room, how many of them have got a healthy baby? So number of women with healthy baby divided by total number of women who are getting admitted, that becomes a proportion. So we teach the concept of CDC, that is count, divide, and then you compare. So when you have only the numerator, you are only counting. When you're dividing it, you have a proportion. Say for example, there are around 5 teams of OG teams that are working in a labor room. Every team can keep a count of their proportion of proportion of healthy babies in their deliveries, or proportion of complications among deliveries. So number of people with complications divided by total number of deliveries you do, and then try to see if this proportion is equally divided. You don't just compare just the number. Okay, they have got 5 complications, you have got 10 complications. How is it possible? Maybe the people or the team which has got the 10 complications had got 100 cases on a day, whereas the people who got the 5 cases have got only 8 cases on a day. So it's 5 by 8 and then there is 10 by 100. So that is how you compare. So you divide and then only you compare. Don't compare the numbers. That's the take home message from qualitative variables. Okay. Then taking it towards rate. Okay. So when you look at rate, change in something over some time, or how quickly a disease can occur in a population. Okay, so this is where we will try to bring an example. Say for example, 100 women were followed up for 10 years, which will together make up 100 into 10, that is 1000 years, and 70 of them developed breast cancer. That's an example. So the incidence rate of breast cancer is going to be 70 new cases of breast cancer divided by the 1000 years, that is 7 per 100 years. Okay, but if we try to calculate incidence, which is just going to be a proportion where 70 people got the disease divided by 100 people, that is 70 by 100, that is 7 per 10. Okay, so there is a difference. Let me try to bring it up with one more example. So 7 out of 100 women will develop breast cancer every year, and this is what is meant by something known as rate. So if you have a quality, you can divide it and try to get, count, divide, compare. So in that rate, ratio, proportion, and this is the rate that we are talking about. And inside rate, it is nothing but a proportion with a time component attached to it. Say for example, 100 women for 10 years, 100 into 10. If I don't add that 10, it is going to be 70 by 100. But here I am doing 70 divided by 100 into 10. So the time component is added, and that will make a difference. But I think we are more commonly, used to seeing an example like this, what we see on the screen. Say for example, after a surgery, how many people are developing an outcome? Or after an endometrium surgery, how many people will develop pregnancy again? Or after an intervention, or I am doing a drug, how many people are dying out of it, or how many people are alive at the end of the day, etc. So on the screen, you see from 1980 onwards, there is a data till around 1994 for around 12 people. Some of them are starting together, around 5 people are starting together into the cohort at 1980, and then some of them are joining at a later point, and you can see that there are 3 people with X, that is the outcome, that is the disease that is happening. So incidence rate is basically going to be 3 divided by 100. So how did I get this 100? 100 is nothing but a total time calculation. One individual into how many years they have contributed. Second individual, how much year they have contributed. So can you see there is 8 plus 10 plus 14 plus 14. So this is what we try to do in survival analysis and outcome analysis based on time, and in all those cases we are supposed to be reporting a rate. So this is IR, or incidence rate, that is 3 per 100 years, which basically means if I follow 100 people for 1 year, 3 people are going to develop this particular disease. Okay, that is the easiest explanation of IR, or incidence rate. So the same thing, the same concepts can also be applied for survival rate and other incidence rate. Even crude birth rate is also a rate. So what are the ratio examples that we know of? We have got sex ratio, we have got death to case ratio, and we also have got a lot of proportions, that is percentage of GDM among the pregnant women who are reporting to my OPD. So I have 100 people reporting my OPD. What is the proportion of GDM among that? Like 25% or 30%, which means out of 100 people who are coming to my OPD, 35 people are going to be, having GDM. Now, there is a misnomer usage of rate in unnecessary places. Say, for example, I say case fatality rate. I am not following up anybody here, correct? It's a cross-sectional analysis. So that is a dangerous territory. So make sure when you are mentioning the term rate, you have got a time component attached to it clearly, so that you can tell the answer in person years mentioning, okay, like in person years. So with that, we have come to the end of, how to summarize quantitative data, how to summarize qualitative data. So just to revise once again, so qualitative data, we have rate, ratio and proportion, and for quantitative data, we have normal and non-normal. Normal is mean plus standard deviation, non-normal is median plus interquartile range. Thank you from my side. Open for questions.
Thank you so much, Dr. Sharon. It was really very elaborate and you simplified the topic very nicely. I don't see any questions in the chat box. If there are any, please put it here so that Dr. Sharon can take them.
Yeah, so I see that somebody has connected to my maths teacher story. Finally witnessing the use of maths in practice after so many years. Really true. So the bottom line is, I went back to my maths teacher and told her, Madam, sorry, I was wrong. Maths is everywhere, and every day on a day-to-day basis we are dealing with maths. And any number calculation wrong, we know the patient is going to suffer. And in our case, the whole population is going to suffer if I miscalculate a number.
So we really need to thank your maths teacher.
Yes.
Yeah. Thank you so much.
Thank you.
Yeah. Dr. Surekha wants to say something. Can you please unmute her? I request our chairperson, Dr. Geeta ma'am, to give her point of view towards this presentation. Please unmute the chairpersons.
Hello.
Yes, Dr. Geeta.
Yeah, Dr. Sharon, it was very excellent presentation and very well explained. I wish more and more postgraduates can really hear this so that they get the fear of biostatistics out of their mind. When I give a thesis topic to a student, the first thing that comes to the mind is like, Madam, will I be able to manage the biostatistics? So we wish to have more lectures, see you more often, and explain to the postgraduate students that it is really very simple and not so difficult. We have more apprehension in our mind. We as doctors, we as gynecologists, we do such complex surgeries, we take such major decisions, but we get scared of something as simple as mathematics. The same applies to finances. We are very poor in finances and we are very poor in mathematics. So I wish that more and more people will actually listen to your lecture and will understand the basics. That is very, very important in today's publications. Thank you. Thank you very much.
Thank you.
Thank you, Dr. Geeta. Now I invite our chairperson, Dr. Harshal, who is from community medicine, to his expert comment.
Hi, good evening, everybody. There was a lot of deja vu moments for me. First of all, let me start by thanking Dr. Vaishali Madam to call me here as a chairperson today. My experiences are very similar to what Dr. Sharon had said when I passed my community medicine exam in final part 1. I actually kept the textbook on the floor and I did a namaste to the department. And I said, this is the last time I'm going to be in this department. And as fate would have it, I had to do my MD again in community medicine and make tally with numbers. Excellent session, Dr. Sharon. This has been a long-standing series of webinar, which I have been taking for decades together with MEU India group, and very nicely presented. Over the years of my teaching, I have developed some questions for the very important, classification of continuous variables, and I would like to share that questionnaire with all of them. I don't want to share my screen. I'll just read them out for you. Those of you who are interested in deciphering which type of variable it is, you can just note it down. And if the answer to each of these questions is a yes, then it's a continuous variable. So the first question is, does mean in this situation make sense? So if I ask you, what is the mean height of the class, that question makes sense. But if I ask you what is the mean religion or what is the mean name of the class, that question doesn't make sense. So means would make sense in continuous variables. That is the first question that I've developed. The second is, are seemingly equidistant numbers really equidistant? Say, for example, he talked about satisfaction. So is very dissatisfied the same distance from slightly dissatisfied as is very satisfied equidistant from satisfied? So you inherently know that the distances are not the same. So these are not continuous variables. In continuous variables, 10 is the same distance from 20 as 20 is from 30. So the distance always remains the same, and we inherently understand that. So distances are the same, means make sense. And the third question you have to ask is, are fractions making sense? Can I fractionate it? A height of 150.5 centimeters makes sense and it exists. But again, we cannot fractionate religion, we cannot fractionate names. So that is a continuous variable. And the last question that you have to ask yourself is, the thing that I'm measuring, is it I'm able to precise measurement? Blood pressure can be precisely measured, although there's a lot of debate about how precisely we can measure that. But in theory, you can understand that height, weight, blood pressure, serum cholesterol, or serum potassium can be precisely measured. And if these four questions, the answer to these four questions is yes, then it is a continuous variable. Something that I would also like to emphasize is, do not dilute higher order variables to lower order variables. So like Dr. Sharan had mentioned the types of variables, if you can collect data on a continuous variable, don't dilute it down to dichotomous or polytomous or ordinal variables or nominal variables. And I'm sure that the next speaker will talk about why we don't do that. Coming to something what Dr. Radhika had asked, what is the clinical connotation of why do I even bother to know this as an obstetrician or gynecologist? One of the many reasons, which I'm sure they would again talk, is that, like you said, when you give a thesis topic, PGs come to us and say, sir, kuch bhi karo, bas isko significant la do. First of all, that is something which I would want to emphasize to all obstetricians and all clinicians. This is not, being significant is not the holy grail in biostatistics. There is no pressure for us to be statistically significant. And secondly, it also informs the doctor to what kind of tests are you going to apply on your data. So for these two, this is where the communication with the biostatistician or the epidemiologist breaks down. So if you are at least well versed with what types of variables are you using, then you have a cursory idea about what kind of tests are we going to use later. And then both of you, your epidemiologist and your statistician, all of you can be happy together. So that was a brief recap of the session and something that I would wanted to share with you and add. Thank you once again for the opportunity, and congratulations, Dr. Sharan, for the wonderful presentation. Thank you.
Thank you, Dr. Arshil. Thank you for those interesting questions and again elaborating the talk given by Dr. Sharan. So now we move to the next session. By now we have seen statistics for descriptive studies, and now we are going to see statistics for analytical and experimental studies. And to chair the next session, we have three personalities, and I would request to share the slide so that I introduce the chairpersons for next session. Yes. So for second session, we have Dr. Nesson, who's going to give us this overview of statistics for analytical and experimental studies. And to chair this session, we have Dr. Yogesh Gura, who is Scientist E and Group Leader, Health Technology Assessment Group, ICMR National Institute of Virology, Pune. I welcome you on behalf of FOXI JOGI and ICOG Masterclass. Next, we have our own faculty, Dr. Reena Jevani. Madam is Professor and Head of Department at HBT Medical College and Dr. R.N. Cooper Hospital, Mumbai. Madam, welcome you to this session. And our third chairperson is Surgical Commander Sushil Chawla, Indian Navy, Consultant and Head of the Department at INHS Ashwini, Mumbai. Sir, you are most welcome to this session. And I request Dr. Reena Jevani ma'am to please introduce our next speaker, Dr. Nesson.
Good evening, friends, and welcome to this wonderful sensitization workshop on biostatistics. And the next speaker to follow up the great first talk is Dr. Manikanda Nathan, who is a FETP consultant from ICMR, National Institute of Epidemiology, Chennai, India. He's a public health specialist and has been a mentor for the India Field Epidemiology Training Program. His research areas include not just the field epidemiology, but also implementation of research and non-communicable diseases, which are a very big aspect of health in India today. And we look forward to hearing Dr. Nason enlighten us about how we can understand different variables and apply different tests. Over to you, sir.
One second, we're just sharing the screen. Now go to Zoom. Go to Zoom.
So as Dr. Nason is sharing his screen with us, meanwhile, I would just like to thank the chairpersons for the last session and also the co-coordinator with me, Dr. Ranjana, for always being there, a shoulder to rely on. I thank her for this, and now Dr. Nason has shared his screen. So sir, the session is yours.
Yeah, thank you, ma'am. Good evening, everyone. And I thank the organizing team for the introduction and providing me with this opportunity. And I thank my colleague, Dr. Sharon, for beautifully setting up the stage for my session. So without wasting much time, let us directly jump into the session as we have limited time to cover the entire topic. So what are we trying to do through these sessions? Definitely, we are neither trying to make you an expert in statistics, nor make you do statistical analysis in any software. Maybe we have to do a different workshop for it. But yeah, then what we are trying to do here? So we are just trying to make you less confused about the statistics. So like as of now, I think most of us, including us, we are all more confused about statistics. Even after like having 6 or 7 years into statistics, we are still confused about statistics. So what we can do is we can make you less confused about the statistics. And at the end of the session, I hope you will be able to interpret some of the common statistical concepts which you will come across in your research studies or while reading journal articles. And one more important thing, you will be confident enough to request what exactly you want for your study from anyone helping you with the statistics part, rather than just depending upon what the other person gives you. So what are the things you will learn from this session? You will get to know about the measures of association which are commonly used in clinical research and how to interpret them. Then we shall discuss about the two highly demanded statistical terms, especially among the clinicians. Those are p-value and confidence interval. And we will also see briefly how to choose an appropriate test for hypothesis testing. And what is not intended in this session, I definitely don't intend to discuss the mathematical calculations behind the statistical tests of significance, or to frighten you with some statistical jargons and formula, or neither to brag about my statistical knowledge. I will try to be conscious of for this particular thing, but if at all anything, these things happen during our discussion, remember this is slide number 4, and pardon me for the same. Yeah, so I am not going to discuss any mathematical formula during the discussion. Now, so you might have already come across this slide in your earlier webinars. So I will just take 2 minutes to refresh this. Broadly, the epidemiological studies can be classified as descriptive and analytical. So again, I want to reiterate that I am not speaking about statistics here. This is the study design types, descriptive and analytical. we divide these two based on the presence of a comparison group. If we do not have a comparison group, then it is a descriptive study, and under descriptive,
Dr. Nason?
yeah. Hello.
Yes, madam.
Please carry on.
Yeah, thank you. So if we do not have a comparison group, then it is going to be a descriptive study, and under descriptive we have a case report, case series, and cross-sectional. Whenever you make comparison between two groups, then the study becomes analytical. The comparison groups can be external or internal. By external, I mean you decide on the comparison groups even before starting the study, like case control study. You know, cases in one group and control in another group, or an experimental study where you have intervention in one group and control group as another group. These are all external comparisons. And by internal comparison, I mean you study as one group and compare two groups during the analysis. For example, we conduct a cross-section study to determine the prevalence of PCOD, and you compare the prevalence of PCOS between the age group less than 15 and more than 15 years. Then it becomes an analytical study because we are comparing two age groups. And if you study only the prevalence and do not tend to do this comparison, then it remains only as a descriptive study. So that's the basic difference. And that's why you can see the cross-section study in both the types, in both descriptive and analytical. And among the analytical studies, the difference between experimental and observation studies is whether the investigating team assigns the exposure or not. If the investigating team assigns the exposure, then it becomes the experimental, else it is an observational study. And within observational, we have case control, cohort, and cross-section studies. So I'll stop the study design part with this. I'm not getting deep into this as this is not the scope of this particular discussion. I just wanted to give a brief idea about the study design because I need to take this particular thing into my discussion later. Now, coming to our first part, the measures of association. So what are these measures of association? And when and why we should use the measures of association? So measures of association quantify an association between two variables. And how do we find the association between two variables? By comparing the groups of two variables. When we compare two groups based on another variable, it becomes, as we saw, it becomes an analytical study. So we calculate measures of association only in analytical studies, not in descriptive studies. So what measure of association to use in what study design? That is very, very important. The common one which we all know is odds ratio, which should be calculated in a case control study. I am not going to discuss the formula given here. I have given it here so that you can refer to the slide later if any doubt arises. So for example, if an odds ratio of 2.0, that is 2, means the cases have 2 times higher odds being exposed than the controls. So we will see with the examples in the forthcoming slides. In cohort and experimental studies, which involve follow-up of study participants, we use something called relative risk or incidence rate ratio. Relative risk 2 means the risk of disease is 2 times higher among exposed than unexposed. Whenever you see that incidence rate, as Dr. Sharan rightly said, incidence rate means always you have person years or person months or person days. So you have person time in the denominator. So whenever you see the incidence rate and when you compare two incidence rates, it becomes incidence rate ratio. And the interpretation is as similar as relative risk. If the incidence rate ratio of 2 means when compared with the non-exposed, the exposed group have 2 times higher rate of developing a disease, whereas in relative risk we say higher risk of developing a disease. That's the only difference. And as you can see in the slide, in cross-section study, we use something called prevalence ratio. You may be coming across this particular term for the first time, but prevalence ratio is as similar as relative risk. The formula, the calculation, everything is same except that the study designs are different. In cohort study, we use relative risk. In cross-section study, we use prevalence ratio. So the prevalence ratio of 2 means When compared with unexposed, the exposed group have 2 times higher chance of having a particular outcome, because here in cross-section study we measure both the outcome and exposure at the same time. We are not following up and seeing whether the one group is developing a disease more when compared to the other. No, we are checking both the exposure and the outcome both at the same time. So the interpretation will be the prevalence ratio of 2 means the exposed have 2 times higher chance of having an outcome than the unexposed. So besides these measures, we have a few other measures of association which I came across in the journal articles, especially with the obstetrics and gynae articles. These are relative risk reduction, also known as efficacy, absolute risk reduction, and number needed to treat. So we are going to see these things in detail in the forthcoming slides. In brief, the relative risk reduction means how much the The relative risk reduction means how much outcome the intervention has reduced relative to the control group, whereas the absolute risk reduction means how much the outcome the intervention has reduced. So both are different. We will see in the calculation in the forthcoming slides. If you see the formula, the absolute risk reduction is subtracting the incidence in the intervention from the incidence in the control group, and RR is doing the same and then again dividing by the incidence in the control group. So if it is confusing for you, please forget about this. Please forget about the formula here. We will see in the forthcoming slides. And the number needed to treat tells us how many number of individuals we should intervene to prevent one adverse outcome from happening. So that is what is called number needed to treat. Now, so this is an example of odds ratio which we usually use in a case control study. In a study to identify risk factors of ectopic pregnancy among pregnant women, the investigators have assessed the association between prior history of cesarean section and ectopic pregnancy, and the OR was 3.48. So what does that mean? So just take 10 seconds and then think in your mind, how will you interpret this? No, it will be time. So I'll give you 10 seconds. Just think in your mind how to interpret this.
People can put it in the chat box, their responses. Please type in your responses if you'd like to do so.
Okay, so a OR in this particular example, the OR of 3.48 means when compared with those who did not have an ectopic pregnancy, those with ectopic pregnancy had 3.5 times higher odds of having a prior history of cesarean section. As you could see, since it is a case control study where we move from outcome to exposure, the study design per se moves from outcome to exposure. Even my interpretation moves from outcome to exposure. So I am comparing the case and control group in terms of exposure. If you ask me whether you can interpret the opposite, for example, when compared with those who do not have a prior history of cesarean section, those who had prior history of cesarean section had 3.5 times higher odds of having ectopic pregnancy. That is also right. Both are same to say. Both are right. So you can go in either direction, right? So this is an example of relative risk. In a study to examine the relationship between BP and adverse pregnancy outcome, and to see the association between elevated BP and preterm birth, the RR was found to be 2.38. So what does that mean? Again, 10 seconds to think within yourself, if not in the chat box. They can also mute and tell. No, I'll have some interaction later. Right. So the RR of 2.38 in this particular example means when compared with those who had normal BP during pregnancy, those with elevated BP had 2.4 times higher chance of preterm birth. So that's the interpretation of RR here. So I could see one.
Two right answers.
Yes, yes. Two right answers.
Very good. I'm happy.
Yeah.
Okay, right. So this one particular point I want to enforce in this forum because this is one of the very common mistakes I have noticed in many scientific journals, like irrespective of the subject area, in even in public health, using OR in cohort in a cohort study and a cross-section study. Of course, it is not a mistake to use OR in a cohort study. It is allowed, but we have to be very wary of this particular fact. OR usually overestimate the association than RR when your outcome is very frequent. For example, if your prevalence or incidence is more than 5%, OR usually overestimates the association. We will see with one example. But the bottom line here I wanted to say is, try to avoid OR in cohort and cross-section studies when the prevalence or incidence of the outcome is more than 5%. Rather, use the relative risk or the prevalence ratio in like in the subsequent as per the study design, RR in cohort and prevalence ratio in cross-sectional. So this is one such example. I just took it from one of my particular analysis. So how let's see how OR estimates the association. So this is a cohort study assessing the association between eclampsia during pregnancy and low birth weight, right? So and you can see the 2x2 table towards the left side. So 50% of the women who had eclampsia developed, gave birth to a low birth weight baby, whereas only 13% among those who did not have eclampsia. And what you are seeing below, the two tables are directly the outputs of the statistical software. If you can see here, the total incidence of low birth weight is 6 out of 498 plus 6, that is 6 divided by 504, which is 12%, which is clearly more than 5%. So here your outcome is more than 5%, right? So which means your outcome is frequent. In such cases, can you see the RR here? It is 3.9, and can you see the OR here? It is 6.9, which is the actual estimate is only 3.9, but your OR overestimates. So when you report OR in such scenario, we actually overestimate the association, which is not right, which is against the truth. So try avoiding estimate like reporting OR in a cohort or cross-sectional whenever you have frequent outcomes, that is whenever your prevalence or incidence is more than 5%. That's the bottom line. Now, what if RR or OR is less than 1? How to interpret that? For example, in association between aspirin intake and eclampsia, if you come across an RR of 0.4, in RR or OR, we say the null value is 1, which means because we are dividing two groups, incidence in one group divided by incidence in another group, if the RR or OR is 1, which means both the groups are similar. So in RR or OR, the null value means it's 1. Now check how much the RR or OR deviates from the null value, which means here the RR is 0.4, the null value is 1. So how much it deviates from the null value? 1 minus 0.4, that is 0.6 into 100, which gives us 60%. So how can I interpret? When compared with those who did not take aspirin, those who had aspirin had 60% lesser chance to develop eclampsia. So this is how we can interpret. I repeat, whenever the RR or OR is less than 1, we can interpret using percentage. And how to calculate that percentage is how much it deviates from the null value. For RR or OR, the null value is 1. So in this case, 1 minus 0.4, which is 60%. So I am interpreting as when compared with those who did not take aspirin, those who had aspirin had 60% lesser chance to develop eclampsia. Next, so the three common terms which are frequently used in clinical research, the relative and absolute risk reduction and number needed to treat. Let's say, take an example. In a study to examine the efficacy of obstetric thromboprophylaxis in reducing long-term risk of venous thromboembolism. So this is the study. Thromboprophylaxis, obstetric thromboprophylaxis in reducing the risk of venous thromboembolism. And these are all the examples which I took from journals. So we are not used to such common examples. I'm sorry if I am pronouncing anything wrong. And in that particular study, the incidence of venous thromboembolism in control arm was 16%, and in intervention arm it was 2%. And how to calculate the relative risk reduction, which is also known as efficacy. This is what, whenever we do a trial, so this is what is called efficacy, relative risk reduction, which means first I will go with the calculation, then I will explain what it is. So what is the incidence of venous thromboembolism in control arm? It is 16%, that is 0.16 minus 2% in intervention arm, that is 0.02, divided by what is the incidence of the outcome in control arm? Again, it is 0.016 into 100. It will give me 88%, which means out of the total incidence in the control arm, that is out of that 16%, how much risk I can prevent if I give this intervention, right? Out of that 16% risk, I can prevent 88% of that risk if I give this intervention. So that's the meaning. That's the efficacy of this intervention, obstetric thromboprophylaxis. And absolute risk reduction is just the numerator of what we have seen here, 0.16 minus 0.02, which is 14%. Why we calculate absolute risk reduction is to calculate the number needed to treat. That is, the number needed to treat is 1 by absolute risk reduction, that is 1 by 0.14 equal to 7. Which means, how to interpret this? We need to treat at least 7 women with obstetric thromboprophylaxis to prevent 1 venous thromboembolism later. So that's the meaning of number needed to treat. So I would like to stop here, and if there is any doubt, we will clarify it at this stage and then move on. I think the concepts are a bit heavy. I know that, so that's why I will try to stop here, and then I will get a feedback whether it is fine, or should I go slow, or can I maintain the same phase, or if there are any doubt, I will clarify it here.
So what I think is, it's an extremely important concept, because when we talk about the efficacy of any treatment, now, for example, there is abnormal uterine bleeding, and we talk about using levonorgestrel intrauterine device. So if I say the reduction, the relief, is 16% or say 2%, it really does not is not absorbed by the patients. So it is a great idea to talk about number needed to treat. So if there are 7 people like you, it will give relief to 1. If there are 100 like you, so many will get relieved. So that kind of a clinical explanation to the patients is extremely useful, and they understand that better, and the reception is better. So I think these basic statistics, even though they might look a little confusing, the basic concepts are, I think you have presented it extremely well, Nathan. And I think people can certainly go and also, just get themselves more familiar with these concepts for the clinical practice, especially while explaining such concepts to the patient.
Thank you, ma'am.
So any of the chairpersons would like to offer their comments, or Dr. Sushil, Dr. Chawla, please.
Ma'am, Dr. Resen is proceeding at a very controlled pace. So my suggestion will be let him go, and we are all enjoying the talk, what is covering. So we'll put his questions for the end if there are any, or any comments.
Yeah, certainly, sure.
Thank you, sir. Okay. Let me move on. So I'm going to end the measures of association with a note on hazard ratio, because this is again another common measure which we come across in clinical research, especially in cohort and experimental studies, where there is a follow-up of study participants to look for the outcome. So hazard ratio is why I have just given a note here is, this is just to introduce this term here. Okay, this is a bit complicated topic to understand the hazard, the concept of hazard, but I will try to explain it here. The hazard ratio is the comparison of instantaneous risk, okay, or the hazard of the outcome between the exposed and unexposed. Whereas the interpretation is similar to relative risk with a small modification. For example, if you conduct a cohort study among pregnant mothers, following them up till 2 years after delivery to look for the thromboembolism episodes, then RR of 3, while eliciting the association between eclampsia and the thromboembolism, can tell you that when compared with women who did not have eclampsia, those who had eclampsia had 3 times higher risk of developing the outcome over 2 years. That is relative risk, because we have followed them for 2 years. Whereas if you calculate hazard ratio and if your hazard ratio also gives 3, we can confidently tell that when compared with the woman who did not have eclampsia, those who had eclampsia had 3 times higher risk of developing the outcome, that is thromboembolism, at any point of time. So that's the only difference. There we cumulatively see the risk for 2 years. Here we can confidently say at any point of time these women are at 2 times higher risk of the control group. So that's the only difference. So I'm not getting deep into the mathematical concepts of it because it is too complicated to handle in a very short session here. So that's why I didn't give any formulas, and I'm just giving you the interpretation here. Next, now coming to the second part of my discussion, which is inferential statistics, which is a continuation of what Dr. Sharan took. Dr. Sharan took the descriptive, or also known as summary statistics, and I'm going to speak about inferential statistics here. So the inferential statistics, it allows us to study the samples and then make generalization about the population from which the sample has been chosen. It is not allowing us to generalize to the entire population. So we have to be very careful about it. It is helping us to generalize the findings to the population from which the sample has been taken. For example, you are doing a study by choosing cases and controls from the hospital. So you can generalize the findings to the hospital settings only. So whatever is your sampling frame, you can generalize only to that sampling frame. So you can only infer to the sampling frame. It's not the universal thing, right? That's why usually in a community-based study where we choose from the community, we can generalize to the entire population. If your study population is going to be only 18 to 60 years, then you can generalize only to the 18 to 60 years, not to the entire population, right? So whenever we speak about inferential statistics, just remember these two terms, p-value and 95% confidence interval. Yeah, only these two terms refer to inferential statistics, nothing else. Your RR, OR, PR, nothing contributes to, nothing is related to inferential statistics. Your inferential statistics means it's only two terms, p-value, 95% CA. We will see in depth in the forthcoming slides. Now, so we are taking a sample from the total population because we are unable to study the entire population due to various reasons, as Dr. Sharan rightly pointed out. We are taking the sample, and in analytical studies, I'm not speaking about descriptive studies here. In analytical studies, we are starting the study with some hypothesis, right? And then we are testing that hypothesis and we are making conclusions based on the sample, and that's where we get this measures of association, OR, RR, PR, and these measures of association are related only to your sample. It's not to the entire population. Now, up to this, at this stage, we speak about mean standard deviation, we speak about median interquartile range, we speak about rate, ratio, proportion, measures of association, everything here related to the sample. Now, but what is our ultimate goal? Why? Because we were unable to study the entire population, we took sample. But our ultimate aim is to know what is happening in the entire population. So, based on this findings in this particular sample, we are generalizing into the population. That's why we always say take a representative sample from the population. That's why sampling is very, very important. If you are not taking a representative sample from the population, then generalization gets difficult, right? So this is inferential statistics. Whatever we obtain from the sample, whatever findings we got in the sample, we try to infer it to the population from where we took that sample, and that's where we get this inferential statistics, which is p-value and confidence interval. So what is hypothesis testing? Before that, I hope everyone knows that exposure variable can also be called as independent variable and the outcome variable can also be called as dependent variable. Both are same. Now coming to hypothesis testing. Any analytical or experimental study starts with the hypothesis, right? Because we are going to compare two groups, there is going to be some hypothesis. So we have two hypotheses. One is null hypothesis and alternate hypothesis. Null hypothesis means there is no association between the exposure and outcome. If it is an intervention study, the intervention will not work. That is the null hypothesis. And the alternate hypothesis is exposure is associated with the outcome. So these are the two hypotheses. And whenever we use the tests of hypothesis, we are going to see all those tests now. Whenever we are going to use the tests of hypothesis, all those tests test the null hypothesis only. They are not dealing with alternate hypothesis. All the tests for null hypothesis, that is, they assume there is no association between the exposure and outcome. Okay, and what is the output of all this test? We get p-value. That is probability. What do you mean by p-value? The probability that something is true, that is p-value. So what we are testing it here, we are testing the null hypothesis. All tests of hypothesis test the null hypothesis, assuming that there is no association. In such a scenario, if your p-value turns out to be less than 0.05, which means the probability that null hypothesis is true is less than 5%, because we are testing only the null hypothesis. Indirectly, it means the exposure is associated with the outcome. So we are rejecting the fact that there is no association between the exposure and outcome, because the probability that there is no association is less than 5%. That's why whenever you come across p-value less than 0.05, we say it is statistically significant, which means that there is some association. That's the meaning. So I would like to stop here for 30 seconds. And if there is really doubt at this stage, please let me know. I will explain it again.
You are explaining it so nicely. We are enjoying it. If delegates have any query, please put it in the chat box. Thank you for choosing all examples related with obstetrics and gynecology, from ectopic to eclampsia to thromboprophylaxis. So it's quite close to our heart. We are relating to it and understanding the things quite clearly.
Thank you. Right. So I assume there are no doubts, and then I am proceeding further.
Sure.
So now that we know that we can get a p-value from the test of hypothesis, we need to know what are the tests which are appropriate for your study based on the variables in your study. So to choose the appropriate test, we need to consider 4 things, right? First, the type of your outcome variable or a dependent variable, whether it is continuous or categorical. Second, the distribution of an outcome variable if it is a continuous variable. That is, whether it is following normal distribution or non-normal distribution. As Dr. Sharan rightly told, we can use the thumb rule to decide that if the mean is more than 2 standard deviation, right? If the mean is more than 2 standard deviation, definitely your variable is following normal distribution, right? Next, third, total number of groups in the independent variable, whether it is 2 groups, because we are comparing 2 variables and there should be a minimum of 2 groups, right? So 2 groups or more than 2 groups. Fourth, what is the type of data, whether it is a paired or unpaired data. By paired I mean whether it is pre or post. Pre or post means paired. If you do a matched case control study, you will match a case and control by using some matching variable. Then the case and control become paired. So these are all examples of paired data. Or for example, when you follow up over a time period, at baseline 6 months, 1 year, then 3 time points become 3 paired data. So these are all examples of paired data. Now, based on these 4 criteria, we should choose the appropriate hypothesis testing, right? Before seeing the various tests of hypothesis, I would like to stress upon one particular thing. You need not know the names of any test by heart, right? I request you only to understand the way in which the appropriate test is chosen, because the table which I am going to show you, it is available over the web, and I will also share the PPT, and if it can be circulated, right? So that is available everywhere across the web. So just get to know how to choose that statistical test. If you get to know, then you can choose it wisely using the tables available in the web. We need not know the test names by heart, because that is how we usually get carried away, and we usually get fed up of statistics by knowing the test names by heart, right? So now let's see how to choose the appropriate test, right? So this is how the table looks. This is based on the 4 criteria which we have seen in the previous slide. Now let's take one example. Association between anemia during pregnancy and low birth weight. So anemia, yes or no? Here the outcome variable is low birth weight, yes or no, right? So can you all type in the chat, what is the type of this variable? Low birth weight, yes or no? I think Sharon, in Sharon's session it was covered. What is the type of this variable? We have only 2 types of variable broadly, quantitative and qualitative. Can we have the answers? Okay, we have some 3 answers. Good. I am expecting more, please. Right. Qualitative. So I think we got the right answer. Yeah. So Sharon's class has really worked. Thank you, sir. So yeah, it is a qualitative variable again, because it's just a 2 categories, yes or no. We can even label it as dichotomous variable, but that doesn't matter. So it is going to be a qualitative variable. If you can see at the end of the table, in the dependent variable, it is either nominal or dichotomous, right? Right. So if you can see the towards the end of the table, there is something called nominal or dichotomous. So that is our outcome variable. Now coming to our independent variable, which is low birth weight, yes or no. Right? We have how many groups are there? 2 groups, yes or no. And anemia is the independent variable. There are 2 groups, anemia present, anemia absent. So again, which is coming here in the first column, 2 groups in the independent variables. Next, whether it is unpaired or paired. So anemia, yes or no, are 2 different groups. They both are not paired. 2 independent groups. So what test we should choose? We should choose chi-square test, right? We should choose chi-square test because it is here in the nominal. The dependent variable is nominal, and in the independent variable it is 2 groups, anemia present, anemia absent, and both are unpaired. So we should choose chi-square test, right? And let's see another example. If you wish to compare the BMI in 3 or 4 different age groups, right? Then the type of my outcome variable is BMI, right? Which is a continuous variable. That is going to be a continuous variable. And let's assume BMI follows normal distribution in all the groups of age, in all age groups. If I assume that it will fall under parametric, that is the first row of dependent variable, parametric, right? And what is my independent variable? Age groups, that is 3 or 4 age groups may be there. So that is obviously more than 2 groups in the independent variable. Now, whether this is paired or unpaired, all the 3 age groups are different. They are not paired, they are independent of each other. So first row, that is parametric distribution, more than 2 groups in the independent variable, and unpaired, we will choose one-way ANOVA. So this is how we choose appropriate statistical test, right? So there are more tests here. I'm not going to tell one by one what are those tests, but if you know how to choose the test based on those 4 criteria, we can choose the appropriate test. And what is the outcome of any of this test? It is going to give you the p-value. Any test will give you the p-value, right? So that is one part of your inferential statistics, p-value. Right? Now, what to do if both your exposure and outcome variables are quantitative variables? In the previous table, the independent variable had groups, right? 2 groups or more than 2 groups. Now, what to do if both my exposure and outcome variable, also known as independent, both my independent and dependent variable are quantitative variables. There are no groups there. Now, what to do? So that is where we use something called correlation. Correlation. If one variable changes, what is the other variable doing? Whether the other variable is also changing, whether it is changing in the same direction or opposite direction. That is called correlation. Right? There are 2 correlations. When both of your variables follow normal distribution, we use something called Pearson correlation. When even if one variable follows non-normal distribution, we use something called Spearman correlation. And again, this is also a test of hypothesis. It is going to give you the p-value. And if p-value is less than 0.05, the null hypothesis is rejected. That is, the test is done with the assumption that there is no association. When it is less than 0.05, the probability that there is no association is less than 5%, which means there is association, right? So that is the basis of p-value. So I have few exercises here. I will do at the end because I think we are running out of time. It's already 6:50. I have 5 exercises to choose to know how to choose the appropriate test. If time permits, I will do at the end. Right. As of now, we have seen in inferential statistics the p-value. The p-value will just let us know whether the 2 groups are different or not, whether there is an association between exposure and outcome or not. Now, how to quantify this association? That's where we see all these measures of association, right? OR, RR, prevalence ratio, everything. Now, how to get this? We cannot do it manually, right? We know the formula, we can do it manually, but how to get this in software, right? So that is where we use this regression techniques. We commonly come across this term regression in many journal articles, in journal clubs, in conference presentations. We come across this term regression, right? There are many usage of regression, but one such usage is quantification of the association, which will give us the measures of association, right? Again, I don't want you to by heart this table, but I'm just explaining you briefly. You can use this slide or you can use this table later. Whenever your type of outcome variable is quantitative, we use something called linear regression to get beta coefficient. Let's not go deep into it because that is very less commonly used. Next, mostly your outcome variable will be qualitative, right? Like for example, low birth weight, yes or no. Whether development and adverse event, yes or no. So those are all qualitative variables. Now, depending upon the study design, we will decide the measure of association. If it is case control, we need odds ratio, as we discussed earlier. To get odds ratio, we will use logistic regression. Similarly, in cohort or experimental, we need risk ratio or relative risk. We will use binomial regression to get that. In cross-sectional study, we use something called prevalence ratio, and again we use binomial regression because, as I told, prevalence ratio is as similar as risk ratio, only the study designs are different. We use binomial regression to get this. We need not do all these things. You just need to know these terms so that you can ask while seeking help. You can say, please do logistic regression for me to get the odds ratio. Please do binomial regression for me to do the risk ratio or prevalence ratio. Or if you attend any workshop to do these things, you will be familiarized with these terms. But these are the usage of these regression to get this output. So we use regression to get the measures of association. Now coming to the next part of the inferential statistics. right? We used two terms in inferential statistics, right? P-value and confidence interval. Now, what is confidence interval? Why we should use confidence interval? Now, we take sample from the population, right? Now, if I am doing one study from the same population, now Sharon is doing the same study with the same sample size from the same population. I will get one estimate, Sharon may get nearly similar estimate, and if you do, you may also get another estimate. We are not going to get the same estimate, whether it is prevalence, whether it is a measure of association like RR or OR. We are not going to get the same estimate. It will vary from one study to another, even if it is from the same population with same sample size. So there is some uncertainty associated with the sampling, which is called random error. There will be variability. So to address this, we use something called confidence interval. So the confidence interval means it is the range within which we assume that the true population parameter is going to lie. That is called confidence interval. And if you use 95% confidence interval, you can say I am 95% confidence that the true population value, the population value can be prevalence, the population can be relative risk, the population value can be odds ratio. But when you use 95% confidence interval, it means I am 95% confident that the true population value lies within these limits. That's the meaning. So I'm not going to explain how it is calculated. No, but the interpretation is, if I am 95% confident that the true population lies within this limit, which means there is 5% chance that it can go beyond this limit also. That's the meaning. And that is accepted universally, statistically, that 5% error can occur. That's the meaning. Now, let's take one example, the study of anemia prevalence among antenatal women. And in a sample of 244, if you are getting the point estimate as 70% and 95% CI as 65 to 75, it implies that I can say that I am 95% confident that the true anemia prevalence among antenatal mothers would lie anywhere between 65% and 75%. So that's the mean, right? So this is, and 70% is for your sample of 244 mothers, and 65 to 75% is for your the population from which you took the sample. That's the mean. Now, in the study of factors associated with low birth weight among newborns, if you find the odds ratio of anemia as 3.1 with a confidence interval of 1.5 to 5.3, we can say that I am 95% confident that the odds of low birth weight among those who had anemia during their pregnancy were 1.5 to 5.3 times higher than those who did not have anemia. So one point I want to say here is, as I told, the null value for odds ratio or relative risk is 1. If your confidence interval does not cross null value of 1, your p-value will always be significant. Your p-value will always be less than 0.05. Right? If it is crossing null value, for example, if your odds ratio here is from 0.5 to 5.3, then your p-value will not be significant. Your association is not statistically significant. Right? Another example with a protective OR of 0.27, in this case, the association between intake of iron folic acid and low birth weight, I can say I am 95% confident that those who took iron folic acid supplementation during their pregnancy were 28% to 98% less likely to have low birth weight than those who did not take iron folic acid supplementation. How I got 28% and 90%? I subtracted the 0.72 from 1 and then 0.1 from 1. So I got 28% to 90%, as we saw in the earlier slide. So this is how we interpret confidence interval. So confidence interval provides more information than p-value. It actually functions as p-value also. P-value tells us whether the association is significant or not. And we can get that from confidence interval also. If the confidence interval does not cross null value, then definitely your p-value is going to be significant. And other than that, it is going to give you the magnitude of the effect. It can give the direction of the effect, whether it is protective or at risk. And it is also going to give the precision of the point estimate. If the confidence interval is wide, your precision is wide, right? Your precision is not good. If the confidence interval is narrow, your precision is good. So your confidence interval has more value than p-value. These things the p-value cannot provide. So in summary, choose the measure of association based on your study design. So don't go with odds ratio in all types of study design. By inferential statistics, we mean only two things: p-value and confidence interval. And we use p-value only in analytical studies. Only when you compare two groups, we use p-value, because we commonly come across requests for p-value in descriptive studies when you do prevalence studies. But when you compare those two, the prevalence between two groups, like between age and gender, then we can calculate p-value. But when you do only descriptive, don't expect p-value. P-value is only for analytical studies, and try to avoid odds ratio in cross-sectional and cohort studies, especially when your incidence or prevalence is more than 5%, because odds ratio will overestimate the association, which is not the truth. Thank you so much. I will be happy to take up any question, and if time permits, I will run through the exercise, which may be helpful. Thank you so much.
Thank you so much, Dr. Sharan. I invite Dr. Sushil to please give his comments.
Thank you, ma'am. Dr. Nason, that was something I must say. The last 3 slides of yours were the crux, and the most important message what we got was a confidence interval is something which is generally avoided or neglected, and the P, because that single word P sticks in everybody's mind. So all have to realize that it's the CI which is more important. So 2 words are more important than a single P. And one message what you gave earlier, that if you are planning a study, write down your ideas and meet the statistician before you plan a study, not after you have done the study and then meet him and tell him, कुछ तो significance निकालो इसका जो study किया है, because then it becomes very, very difficult to find a significance, and get the difficult part is it comes later. So it's better to meet the statistician before we do the study rather than meet him afterwards. And I really thank the organizers as well as Dr. Nason for his excellent talk. Thank you very much, sir.
Thank you so much, Dr. Sushil. Now I invite our next chairperson, Dr. Yogesh Gurao, who's scientist in NIV, to give his expert comments.
Yes, yeah, a very good evening to everyone. I must appreciate the efforts done by Foxy, ICOG, and Jogi for arranging such an excellent web series in which they selected a topic on research methodology, and that too that is focus on basic statistics. And what a good thing for every participant that they are getting this kind of knowledge from the young scientists from National Institute of Epidemiology from ICMR, which is a very prestigious institute in India. Okay, I must also appreciate the efforts by Nason that he has used all the examples for this obstetric and gynecology, so that the audience who may be clinicians who are practicing, however they are interested in research, at the same time who may be PG students who are listening, so they can correlate the things, right? So he has very nicely first explained about the various study designs like observational and analytical. I must say that basically the person should at least participate in every kind of study. So if he or she will participate in such a studies during his or her academic career, he will get all those important knowledge, because this learning the statistics in 2 hours, it's a very easy thing, and we will just, it's a volatile subject, basically we forget the things very easily. So my humble request is that please try to participate in as much as a studies as a co-investigator, or try to have studies by your own. Dr. Nason has also informed about these associations and these various inferential statistics. In a very nutshell, he has given shown us the very important tables. So these 2 tables can inform what kind of statistics we can basically use. So we can just paste all these tables if you are having if he is going to share these slides to all the participants, right? So this is a very, very important thing. So I must again, I would like to thank Dr. Vaishali and Dr. Radhika for giving this opportunity to me. to have a little bit of interaction with you. And the most one line message I would like to give to all obstetrics and gynecologists here: whatever evidence you are going to read from the journal, prestigious journal, please try to see what is the sample, how are the inferences they have done, what is how the meta-analysis is being done, and should I use those evidence in my clinical practice? Because it is us who has to decide whether should I go or not to go. Journal will not tell you have to go or you don't have to. It's our own decision, and that decision, when you make implement in your practice, then and then only you can able to get the result. So this is the most important thing I would like to share from my side. Thank you.
Thank you so much, Dr. Gurao, for those crisp comments. And Dr. Sharon and Dr. Nessie. Yes, ma'am.
I would like to just say one thing, that in India, we are doing a lot of clinical work, and I would urge all the obstetricians and gynecologists not to be scared by the statistics and the tests which have been listed. Honestly, I am also one of those who forgot mathematics once I took gynecology and science. But what has been said is that if it is not published, it is not done. We are doing a lot of clinical work. We need to put a little effort into data collecting and using that raw data, translating it into good research. And for that, as was beautifully mentioned by Dr. Seshan, is have the statistician in the loop from the beginning. And as mentioned by the first speaker, even if there is no positive result, that both the arms are equal, that itself is also an important finding, that there was no difference between the two groups. So friends, I think we have to use this ground knowledge of statistics, definitely take the help of our statisticians and move forward and publish what you do. Thank you so much for allowing me to be part of this, and all the best to all those who are listening. Thank you.
Thank you, Dr. Reena. Thank you so much. I think all the senior faculty who have been attending have appreciated Sharon and Dr. Nesin, Dr. Manjupuri. Dr. Charmila has requested for the exercise. So Radhika ma'am, should we go ahead with the exercise right now?
So what I suggest, Vishali, let Dr. Ranjana give the vote of thanks. And then people who would like to stay back can do so, and then, rest can, because I'm sure people are busy too. So let's close the session and then we can wait back. If it is okay with Sharon and Nathan. Is that okay with you, please?
Yes.
Yeah, fine. Yeah, so let's go on with the vote of thanks. Let's, close the session, and then we can sit back and have the next 10 minutes, because we have already overrun the time.
Yes. Dr. Ranjana, would you like to go ahead with the vote of thanks?
Okay, I thought that you are giving the
yes,
vote of
yes, I was, but Dr.
Okay,
Radhika
I'm sorry.
But you go ahead. You go ahead.
Dr. Vaishali, please.
Yeah. Okay, ma'am.
Apologies for that. Yeah.
No issues, ma'am. I thought you were suggesting something.
No.
Thank you so much for an excellent session. And we obstetricians, we are always inclined to research. Many of us are having PG students. We are professors at medical colleges or DNB teachers. But every time when biostatistic comes, and if we find someone who can simplify it to this extent, we just love to attend this kind of conversations and discussions. Dr. and Dr. Nesin, you have really given us a very good overview today, and we all have enjoyed it. And for this wonderful session, I would like to thank President Foxy, Dr. Rishikesh Paisa, Dr. Lakshmi Shrikhande ma'am, who is Chairperson ICOG, Dr. Parag Biniwale, Vice Chair, Dr. Madhuri Patel, Secretary General of Foxy, Dr. Ashok Kumar, who is Secretary ICOG, and our advisors, Dr. Suvarna Khadilkar, Madam, who is Deputy Secretary General Foxy, and Dr. Geeta Balsarkar, who is Editor-in-Chief of Jogi, and today she had also joined us as a chairperson. With your guidance, we are able to conduct this session, and thank you so much for all your encouragement. Dr. Radhika ma'am, we both, Ranjana ma'am and me both would like to thank you for this excellent planning, and we are really enjoying working with you. Thank you, Dr. Ranjana, for always being there as a co-coordinator. And really want to thank our chairpersons for today's session, who are dear friends. Thank you so much for spending time and giving your valuable comments. And Dr. Sharon and Dr. Nesson, excellent sessions. So thank you once again. I would also like to thank the ICOG staff, which gives us a very good support conducting these planning and conducting these sessions. So thank you so much, Nilima and the whole team at the office. And should we go ahead with the exercise now, ma'am?
Yeah, so thank you very much, everybody. Special thanks to Dr. Vaishali and Dr. Ranjana. Sorry for the confusion that I created.
No, ma'am.
So I think, can we go on with the exercises, please? I think majority of the people would like to wait back and.
Yes, ma'am. I think everybody's interested in the exercises.
Yes, yes. So please, Nathan, you can go ahead with that.
Okay. Thank you, ma'am.
So just a minute, Nathan. ICOG team, Nilima or whoever is sitting there, how much time do we have? Can we take about 10 minutes, please? Is that okay with you?
Yes, ma'am. Yes, ma'am.
Okay, sure. Please go ahead, Nathan.
Yeah. So these are exercises to choose appropriate test of hypothesis, which we saw in the table, right? So let's take the first example. In a study to identify risk factors of ectopic pregnancy among pregnant women, if you want to find the association between prior history of cesarean section and ectopic pregnancy, so what test should we use? I will show you the table. So think in terms of those 4 criteria. One is the type of outcome variable. So first, which is the outcome variable and which is the outcome variable, and then the type of outcome variable. If it is continuous, whether it is following normal distribution, or how many groups are there in the independent variable, and whether it is unpaired or paired. So just take 10 seconds to look at the question. I am going to show the table next so that you can choose the appropriate test and then you are going to answer. I'm going to the table now. Yes. I would love to have the answers in the chat box. Even if it is wrong, it's okay, because even now we make mistakes in that. So I think we can have a discussion if we have the answers in the chat box.
Can I see the question again, Nathan? Sorry, I was typing something on the. So the answer would be dichotomous, yes or no?
Yes,
outcome
so
is yes or no?
Yeah, so we need to know the test name, which is the appropriate test of hypothesis here.
Yeah. So I'm just speaking
for
making things look simpler. So it's a yes or no answer, and the dependent variable is the ectopic pregnancy,
exactly.
And there are only 2 groups here, isn't it?
Exactly. A previous history of cesarean section, yes or no?
Cesarean section,
so
yes.
Independent variables, there are only 2 groups.
Correct. So based on that, the question is, which of the tests can be used?
Yes.
Right. So in case the outcome is going to be parametric or non-parametric. So I think it was very nicely projected how to know whether the distribution is normal or not, and that was by the standard deviation. Here we assume that it is parametric. What do you say, Nathan?
Yes, ma'am. So we use parametric or non-parametric distribution for quantitative variables. Numbers. So here the outcome variable is a qualitative variable, which is ectopic pregnancy, yes or no. In that case, we need not use the criteria. We directly go to the third, nominal or dichotomous.
That is exactly what I was wanting to highlight. So when it is categoric variables, or in other words, qualitative variables, one need not go into the parametric and non-parametric distribution of data. You straight away go to the 4th row, and that is the chi-square test.
Yes.
Simple.
So
yeah.
Yes, exactly. You are right, ma'am. So I think we got 2 answers in the chat box also. Oh yeah, I think we got some 4 or 5 answers. Yeah. The answer is chi-square test, right? Which is very commonly used. I'll show the next exercise. In a study to examine the relationship between aspirin intake and blood pressure among pregnant women with eclampsia. Yeah. Let's assume the BP follows normal distribution, right? Let's assume that. Now, what test we should use?
So I suggest you start from the top. So try to find out which is the exposure, which is the outcome. So then do step by step. Can you show? Okay, Madam wants to check. I hope the question is clear.
Aspirin and high BP.
Yes.
No, aspirin and BP. Aspirin and blood pressure.
Correct.
Not high BP.
Yeah. Sorry.
If I say high BP, then it becomes qualitative variable. High BP, yes.
Right. Absolutely.
Here the outcome is just blood pressure, so it still says as the quantitative variable, and
it's a normal distribution.
Normal distribution.
So 2 variables, BP and aspirin, and the outcome is in a normal distribution. So the answer is very clear here.
We got 1 answer. Others? So we'll wait for 2 more answers just to say if it's correct or wrong. Okay, we got 2. We got 3. Very good. Very good.
Yeah. So the outcome variable, can you see the pointer here? Yes. So the outcome variable is like a normal, quantitative variable following normal distribution. So I will choose the first row, that is here the parametric row, and then the independent variable is aspirin, yes or no. This is 2 group and both are 2 different groups. It is unpaired, so I will choose student T test, right? Or unpaired, also known as unpaired T test. Now comes the next exercise. So in a study to examine the relationship between epidural anesthesia and post-operative pain. Okay, and the pain is measured using pain score in the range of 0 to 5. That is how we measure the pain. What test you will use now?
So again, there are 2 variables, and the outcome is in numerical values from 0 to 5.
Yes, ma'am.
So it is certainly not paired, because the follow-up of the patients is not getting done. So it is simply the epidural followed by pain relief, which is rated on the score chart.
Yes,
0 to 5.
Yes.
So the first one, there are 2 group of independent variables, parametric, rank sum. Sweetie Soni says rank sum.
Okay.
Okay.
So answer. We got 1 answer. Again, we need more answers.
This is a very common scenario. We face this in our day-to-day practice. So it could be pain, it could be any ranking. It could be amount of bleeding, whatever.
Yes. So I think we got all right answers. Okay.
Absolutely.
So basically, any time the scores or the discrete variables, it usually follows non-parametric distribution, that is non-normal distribution. So whenever you see scores or discrete variables like whole numbers, score can be 0, 1, 2, 3, 4, 5, cannot be 1.5 or 2.5. So in that case, directly go for non-parametric, this row, and then here there are 2 groups. There will be 2 groups. One group which has taken epidural anesthesia, one group, the other group which has not taken epidural anesthesia. These are all 2 groups, unpaired. So we will go manually rank sum test.
So what you can we go back to that chart again, Nathan, please?
Yes.
So what you have highlighted there is the mean ranks. So while you take the means there in the parametric, here in the score that the patients, whatever is
Yes,
the score.
that is basically the statistical part behind this test. So the student that the T test and all, it compares means, whereas in Mann Whitney and Wilcox and all, it compares ranks rather than means. So
Exactly.
let's not get into the so because
no, I don't want a discussion on that. I just wanted to bring everybody's notice to that. That's all.
Okay.
Attention. Yeah.
Right. So I'll go to the next case, like last two. So let's say we are conducting a matched case control study to examine the relationship between anemia status and low birth weight, which means we took low birth weight babies and normal weight babies, and then we examined the anemia status during pregnancy, and then during the process we are matching. Yeah, so that is called matched case control study. In this scenario, we are matching for some confounding variable. Let's say, for example, the like premature delivery, like whether they are premature or not. So some matching we are doing, right? In a matched case control study. In this scenario, what test we will use? Your outcome variable is low birth weight and the independent variable is anemia status.
So when you say you have matched, you want to say that the two groups are matched for this parameter, isn't it? For this variable, and that is preterm.
No, yeah, preterm. Some variable. I just used the example of preterm, but it can be
for
any
the
other
ease of
confounding
understanding.
variable.
Yeah, so that's okay. So for the ease of understanding, we have now matched for preterm, isn't it? So the two variables are anemia and the low birth weight, and the variable which has been matched for is preterm.
Yes. Add it is. Finally, we have got two different answers.
Yeah. So go with one by one. So there is like a gross difference in both, no? So can we try to fix which row we are going to look first? So what's our outcome?
Low birth weight is the outcome.
So our outcome is low birth weight, which means I have already given whether it is low birth weight, yes or no. It is not just birth weight. If I have given only birth weight, it is a continuous variable. But here we have categories already. Low birth weight, yes or no. So we will directly go with the last row, the nominal or continuous. Nominal or dichotomous, sorry, this row. And then within this, what is the independent variable? We have anemia status, yes or no. Again, how many groups? We have two groups, right? We have two groups. And within these two groups, whether it is paired or unpaired, it is actually paired because we matched two groups based on some variable. So basically two groups now become paired based on some variable. So we cannot say like these two groups are independent of each other. These two groups have been paired based on some variable. So it becomes paired. So in matched case control study, in such scenario, we use something called McNemer variant of chi-square. McNemer chi-square. Okay. Yeah. So coming to the, I think, yeah, that's it. Yeah. So I removed the last exercise. Okay. So that's exercises we have.
Yeah, so just answering to what Dr. Lata was trying to tell, it looks all easy and good now. What if we close the Zoom call and then go read a paper? So what I would try to do is, go stepwise. Let's not jump in. You read it, find out what is the exposure, what is the outcome, what is the type of variable, and then you start looking at the table and have a printout of that right below your desk, or have a photo on your mobile and keep it handy. We are not expected to learn the names, correct? So the process is important. The steps in mathematics is important, For every step you get marks. That's how we are taught. So here also the same thing. Steps are the marks.
So I'll just show one journal article. Now you may be able to understand better the statistical analysis part, right? So this is an article. I'll just see the
association between proteinuria and adverse pregnancy outcomes.
Yeah. So this is the objective is to explore the association between proteinuria and adverse pregnancy outcome. So the adverse pregnancy outcome is definitely the type of outcome variable is going to be yes or no. Outcome, our adverse outcome, yes or no. And the proteinuria, it can be both the ways, right? It can be either whether there is proteinuria, yes or no, or we can also measure the urine protein level. It can be both continuous or categorical. So we can analyze in both the ways. Let's see how they have done.
So this is one section we usually avoid reading, correct? This is like, it has got all the jargon, so I will be like, okay, oh, this is difficult, I'll go straight to results. But now the point is, after this class, we want you guys to start reading the statistical analysis part, because these are the words that we have tried to, break down today. You can see normal distribution, continuous variable, means plus standard deviation, compared among various groups using ANOVA and student t-test.
So can we see here the continuous variables with a normal distribution were presented using mean standard deviation and compared using ANOVA and student t-test, because that is lying in parametric row, right? Similarly, continuous with the skewed distribution were presented using median and interquartile rates. That was first part of our class today. Sharan took. Whenever there is non-normal distribution present with median and interquartile rates and analyzed using Kruskal Wallis test. That is the second row, our non-parametric row of our table, right? And similarly, categorical variables are presented using frequency and percentage and compared among the groups using chi-square test. Because it is independent group, they have compared using chi-square test. And this is where I differ. A logistic regression was performed to look at the severity. So logistic regression will give you odds ratio. If it is a case control study, yes, you can use logistic regression to give odds ratio. If it is a cross section study or a cohort study, it is better to use binomial regression to get relative risk or prevalence ratio rather than odds ratio, if the total percentage of adverse outcome in this particular study is more than 5%.
Very clear. I think that's a brilliant presentation, and the last one was really the cherry on the cake. People have stayed back despite the complications and the challenge of statistics. We started saying that biostatistics is difficult, but I'm sure now everybody is going back enlightened and extremely happy. So thank you so much. Dr. Lakshmi is back. I think she had to leave for a few moments. So the vote of thanks has already been delivered. So because session was closing, so we wanted, they had exercises. So we invited people to stay back, those who were interested and those who were otherwise occupied could leave.
I am so happy, Dr. Radhika, that today's session also went on very well as usual, because you are there sitting. And this exercise was really, I think, must be appreciated by everyone. And I'm so happy that so many delegates were participating in your exercise. It means that those who stayed back, they are really interested in learning. So, I mean, I am really motivated to have this series more and more, because the delegates are getting benefit out of all these research methodology web series.
Yeah, so thank you so much. Thank you once again, Dr. Shrikante, for taking up this topic. And I think Sharan and Nathan,
yes,
thank you so much.
Both
that was a huge,
mind-boggling. I mean, it was really too much.
Hugely energetic performance. Thank you so very much. We will meet again.
Stop recording. Yeah.
Okay, ma'am.
In the beginning only I said they are so energetic, so passionate, the way they were teaching.